Tonight on Insight, back from the dead.
I felt a hard hit pulse, and then all of a sudden she fought her way back.
You effectively died.
That's correct. It was 15 minutes, but I was pretty dead.
How long did your heart stop beating for?
Apparently 46 minutes.
You go so far as to claim that death is reversible.
We have hours of time after a person has turned into a corpse. It's not a claim that I make, it's just a fact.
Hi, I'm Jenny Brocky. Welcome, everybody. Good to have you with us tonight. Cassandra, in December last year, you effectively died. Didn't you? What do you remember of what happened leading up to that?
What I remember, I was at Coogee Beach going for a daily swim, and I was swimming out the back, and I went under the waves, and that's actually all I remember.
So the last thing you remember is
diving under the waves.
It's going under. Now, Neil, you saw Cassandra. You were swimming that day too.
I was indeed, yes.
You saw her with her face in the water. What did you think at first?
I thought she was looking at fish. She had goggles on, and I thought she was just having a look underwater.
So what did you do?
I waited. It's a funny thing. I felt there was something wrong, but I didn't act straight away.
Now, there were a few reasons you didn't act, weren't there?
Well, you don't go grabbing a woman who's, you know, in a bikini floating around in the water minding her own business. I mean, not since the 80s at least. That was considered okay, so I did hesitate, Jenny. I did hesitate, and I watched her and tried to figure out what she was doing.
How long did you wait?
Look, I'd love to know exactly, but it would have been a couple of minutes because I was making my way towards her. She was about 20 metres out.
So a couple of minutes that her face was in the water,
yes,
at least?
Absolutely. Well, I wanted to be certain that she wasn't just holding her breath.
And what happened when you realised that something was wrong? How did you realise?
I saw a wave. There weren't big waves that day, but there was a fairly substantial wave, and she floated over it. And her body was completely limp. And it just flowed with the wave. There was no muscle tension whatsoever. And that looked very wrong. And so I got over to her and I actually leant over and I screamed, "Are you okay?" Which seemed rather strange, but it was the best thing I thought I could do at that point. And as soon as she did not respond, I flipped her over.
And what did she look like?
She was... I'm not a medical practitioner. I know we've got a lot of people here tonight who are, but I know that she was dead. I know that she was... Her lips were purple and her face was completely grey, and there was no signs of life. There was no movement. There was no breathing. She was very bloated. I think she'd swallowed a lot of water.
How long did it take to get her in?
Probably about a minute and a half, 2 minutes to actually get her from the position she was once I'd grabbed her. I knew that was an urgent...
We're talking at least 4 minutes then.
Absolutely.
Between when you first spotted her and goodness knows how long she'd been there before you spotted her.
Well, that is the big question. That is the big question, how long she was there. Yeah.
Matthew Oliver in LA, thanks so much for joining us. Now, you're an emergency doctor based in Sydney and you just happened to be on the beach that day. What shape was Cassandra in when she got to the shore and when you got to her?
Well, by the time I got to Cassandra, she was lifeless. There was no signs of life whatsoever. There was a large crowd around, and the lifeguards were actually already there starting CPR. But I kind of went straight into a medical mode, and there were a number of steps that occurred and saved her life, and that was one that the lifeguards did early CPR. They were straight in action, doing really good chest compressions. The second thing they did was put the defibrillator pads on, and that actually helped me enormously because by putting those pads on, it told me that the heart wasn't in a shockable rhythm. The primary problem for her heart to stop wasn't the heart itself, that something else was going on.
What did you do next?
Then I guess the most important thing for me was to provide ventilation and oxygenation. And that's kind of going away from the standard CPR type protocols that are commenced in the community. And so I was using the lifeguards, and we've managed to piece together bits of equipment that enabled me to provide quite vigorous ventilation. And pretty much within, I'd say, a minute or two of doing that, we actually started getting a good response. So we actually started feeling a pulse. A short time after that, her breathing came back. And then really it was a task of supporting her breathing with positive pressure and the ventilation and oxygenation. And within a very short period, again after that, she started moving. And by the time the ambulance arrived, she was actually awake, and she was moving all arms and legs, and her eyes were open. So I knew from that point, when she was being loaded into the ambulance, that she would most likely have a fairly good recovery.
Cassandra, piecing all these bits of your story together later, have you got any sense of how long you were out in this process?
No, I don't. I mean, I've heard from people that it was 15 minutes, but I was pretty dead, so I don't know.
You were pretty dead.
Yeah. A bit dead.
And do you remember anything of that time?
Looking back, it was just like being asleep, but with no dreams. It was that sort of same sensation. And
when you say like being asleep, you mean just a complete blackout, that you remember nothing? Or are there things that you remember?
There were no lights, no tunnels. There were no guys with long grey beards and white robes. It wasn't hot. No, I think there's a few things. There are very few things that I would agree with Kerry Packer about, but there was a big fat nothing there.
Pretty much nothing there. Yeah. Do you remember coming to?
Patches of it. It was sort of like the flashlights of, it's like having photographs sort of flick between your eyes. I remember coming to and having a sea of faces, complete strangers around me, like very, very close to my face, and peering at me. That was one memory that I have of coming to.
Neil, what happened when she came back? You were on the beach there. You were beside her?
Yes, I was to Matthew's right, and I was holding her wrist, doing an attempt at feeling a pulse. And
did you feel anything?
I did eventually, yes. When the guys, Matthew and Luke, who was giving cardiac massage, managed to actually get Cassandra back, I felt a hard hit, one really good hard hit pulse.
From her? Yeah,
and I'm going, oh, I felt something. And then all of a sudden she fought her way back. You know, you could really feel it.
In what way
could
you feel it?
Wham, wham, just the pulse. Just the pulse. It was like she came back really hard and really strong, and she felt like she wanted to come back. I think she was so lucky that Matthew was there and that Luke was there, and that particularly Luke, who was beating the hell out of her.
Luke was the lifeguard, yeah?
Luke was the lifeguard, that's right, and he was really not giving up. He was on a mission, and I think everyone was. Matthew was ventilating her, and I was talking to her at the time, going, you know, come on.
Matthew, when you said you sort of broke the protocols by giving her oxygen, what do you mean?
Normally people in the community collapse because of heart attacks, so lack of blood supply to the heart. So the main principle there is to get early good chest compressions and get the defibrillator pads on. However, in Cassandra's situation, which is a very rare situation, her problem wasn't actually a lack of blood supply to the heart or actually anything to do with the heart, so that, in other words, her lungs were full of water and she wasn't getting oxygen into the blood. The main goal for her in this instance was ventilation. And the only way that I knew that is really through my training. There's no other way.
Yeah. So, Cassandra, you chose the right beach on the right day with the right guy very nearby.
Of course, it was pre-planned. Yeah.
But incredibly lucky he was there, presumably.
There is luck on every front. It was It's so lucky it's almost not true.
Ron, you're Cassandra's neurologist. What sort of state was she in by the time she got to you in intensive care?
I have to say I was very impressed. When I first saw her in intensive care, she was already up, sitting in bed, and having known her from before, she already had her usual sort of slightly dark sense of humour back. I've got to say, she looked fairly normal.
How did you know her from before?
Because she was my patient earlier for her epilepsy.
And you'd had an epileptic fit in the water? Is that what had happened?
Theory.
That's the theory, but no one really knows.
No.
Okay, sorry, go on.
And basically, you could see that basically the fundamentals of her personality were there, and a lot of the higher order functioning was there. The major issue was with some memory and attention issues, and that sort of played itself out over the next few weeks.
Colin, in June last year, you had a cardiac arrest. How long did your heart stop beating for?
Apparently 46 minutes is what I've been told.
So you were effectively dead for all of that time?
Mm-hmm.
And let's backtrack here a little bit. When did you first think something was wrong? Tell us about the moment when you first thought something was wrong. Where were you?
I was just sitting on the couch. I just got a bit of a heavy sensation in my chest. That was it, really.
And did you immediately think to call an ambulance or call a doctor?
Really. Not really. It was, I knew something was wrong, and obviously my first thought was to talk to Sinead and get her to...
Sinead, what were you thinking?
It was just, you do a lot of reading on heart attacks and so forth, and just trying to go through the different, what was happening to him at the time, and not all signs were there, so we weren't.
So at this
really
stage,
quite
he's
sure.
conscious. He's just got pains in his chest.
Yeah, it was
and how long did you wait
pale.
before you called an ambulance?
We called Nurse on Call at first, and they were on the phone for about 10 minutes, and they talked us through a lot. And then Colin kind of said, "Oh, I think I'm okay. So just hang up." So we hung up, and then he continued on that he still wasn't well. So I said, "No, I think we need to speak to them," and they actually called the ambulance.
Now, when the ambulance arrived, you made a very crucial decision about where you wanted to go when you were asked which hospital you wanted to go to. Tell us which one you chose and why.
I chose the Alfred, and I really don't know why. This
is the Alfred in Melbourne.
The Alfred Hospital in Melbourne, yeah. And I think, looking back, maybe it was because I'd heard a bit about their trauma units and the stuff they do in there, and
but for some reason you just asked for the Alfred.
But it's unlikely that even getting in an ambulance you would normally get a decision or a choice where you want to go.
Yeah,
just
I wondered
sort of
about
you
that.
Off and that's
but
it.
they asked you, right?
Yeah. So.
Yeah. Now, Stephen Philpott in Melbourne, you're an intensive care specialist, and you just happened to be at the Alfred late that night. What was the first thing the doctors at the Alfred did once Colin's heart stopped beating?
Well, Colin was lucky enough that he was in the emergency department. When his heart stopped beating, he was already attached to a heart monitor. The first thing that the emergency doctors did was commence cardiopulmonary resuscitation, chest compressions, and it was about 5 or 6 minutes after they'd started chest compressions that I was walking through the department with a colleague of mine, and we poked our heads into the cubicle to find out exactly what was going on. What we did was attach Colin to a machine called an ECMO machine, which basically draws blood out of the circulation using a large tube inserted into the major vein of the body, puts oxygen into the blood and then returns it through another tube inserted into the main artery of the body. And by doing this, we can maintain the circulation. We could maintain Colin's circulation, even though his heart wasn't beating.
And what did you do after that? You cooled him as well. Can you explain how cooling works? What did you do?
Well, cooling the body temperature is thought to protect the brain during a period where it's not receiving enough oxygen. It's becoming quite a critical part of resuscitation. We're becoming more and more aware that it's very important to preserve brain function. So what we did was, while Colin was receiving his chest compressions and while we were inserting the ECMO cannulas, we were infusing a large volume of ice-cold saline into Colin's veins, and packing his groins and his neck with ice to try and lower his body temperature.
Now, if Colin had gone to any other hospital in Australia, would this have happened?
I think it's unlikely. There's very few hospitals that would have the capacity to do this in an emergency. I should point out that it was 11 o'clock at night, and he made a very good choice in his hospital on that night.
And why is it just being done at the Alfred?
We are running a trial, which means that we are constantly ready to insert ECMO cannulas at very short notice, including during chest compressions.
But usually it has to be during business hours, is that right?
That's correct. Ironically, the reason that we were in the hospital at 11 o'clock at night was because we'd spent the day putting a patient on ECMO at another hospital in Victoria, and we just happened to be returning to the hospital, wheeling the patient up to the intensive care as we walked past Collins Bay when he had his cardiac arrest.
What is it about you two? How did you both manage to pull this off? Were you aware of any of this going on, Colin?
Not in the hospital, no.
Any memory of what happened in the hospital?
No.
Any memories from when you were gone, when you were dead for that time?
Don't recall anything.
Sinead, were you aware that this was a kind of really unusual procedure to have?
Well, I didn't know a lot at all, actually. The last I saw, Colin went away in the ambulance, and I was on my way to pick him up, not knowing that what had happened in the interim.
Sam Parnia in New York, you've been using this same technique in Long Island for more than 3 years. Why?
One of the goals that we have to have is to try to preserve brain cells and other cells after a person has died, because we now understand that it's only after a person's heart has stopped that the cells inside their body start to undergo their own process of death. And that actually, contrary to our views, which was that we thought we only had 6 to 10 minutes before brain cells become permanently damaged, we now know that we have a lot longer period of time. And therefore, ECMO is a fantastic way to essentially deliver oxygen to the brain and the heart and other organs, and prevent the cells from undergoing their own process of death or slowing it down, while buying time for physicians to go and fix the underlying problem that had caused the person to die in the first place. And when that's combined with cooling and the hypothermia treatment, then this really gives us a very prolonged and extended period of time to go back and fix, for instance, a heart attack.
And you go so far as to claim that death is reversible.
Well, it's not a claim that I make, it's just a fact. Because if you think about it, we have a very fixed perception of death that really goes back centuries, if not millennia, because only until a few decades ago, when a person's heart stopped, there was nothing that you could do to reverse that. Now, obviously, if you have been left dead for a very long period of time, then the cells in the brain and other organs have undergone their own process of death. And at some point, they reach irreversible and irretrievable damage, such that no matter what we do, we cannot bring them back. However, the key discovery in the last 10 years is that it's not just 6 to 10 minutes, that we have hours of time after a person has turned into a corpse, whereby with the right medical care, we can not only halt the process of cell death, but also restart the heart and bring back a whole person, fully intact, without brain damage. And that really is the revolution of resuscitation science.
You talk about hours.
This grey zone in which a person has died, but the cells are still viable, can go on for hours. There's lots of research that demonstrates brain cells can be viable. This was done and published 10 years ago in Nature Medicine, where they biopsied brain tissue from cadavers who were in a mortuary. And they managed to grow brain cells in the laboratory up to 21 hours after a person had died. There are also incredible case reports of patients who have been found literally dead hours after their heart had stopped and who were then brought back to life. For instance, the longest case that I have seen that's published in the medical literature is a Japanese woman who was found at least 4 to 10 hours after her heart had stopped in a forest by a passerby, and she received 6 hours of resuscitation using ECMO after she was found, and she left the hospital 3 weeks later and I've been in touch with a physician. She had a baby in the last year.
Well, I would dispute what Sam said about what death is. We've bandied around the word death here, like Colin dead for 45 minutes. I'm very uncomfortable with that.
How do you feel about him being resuscitated?
As time has gone on and I've seen his condition worsen, I'd be saying, don't do it.
Tonight we're talking about bringing people back from the dead, new techniques and the ethics around making decisions to revive people. Wendy, your brother Trevor was revived after he suffered a heart attack at the football. How long did his heart stop for?
We've been told a few different things, but about 45 minutes. All I know was that someone started CPR pretty quickly, and then they had to get him down because he was at the top, one of the top tiers at Etihad Stadium. So they had to clear people away and put him on a board and strap him up and take him downstairs before they could do a lot of stuff. But people have said that he had defibrillation and all that sort of thing there. So.
And what happened after that?
He was in ICU for quite a long time. They couldn't get him out of the induced coma. They had lowered his temperature, and then when they tried to bring it back up and bring him out of the coma, it took a long time, and they weren't getting any responses from him.
And did he get this ECMO machine? No. But he got the other things, the cooling of his body and so on. Yes. What sort of person was he before all this happened?
He liked to associate with people younger than him. He was a very handsome man. He was a bit of a chick magnet. He sort of would go out and all of the girls would like to, talk to him. Very social butterfly, not a stay-at-home person at all.
And now?
Well, now he's in an old age nursing home, so he doesn't do any of those things anymore.
We've got some footage of him here that is taken quite recently.
Yep.
What sort of damage did he have?
Well, he can't speak. He's got aphasia. He's incontinent.
He's motioning there about his
that's
heart
how he
and his
tells
head. That's
people, I had a heart attack, I've got brain damage now, and that's his life now, living with people who are 80 plus.
You were explaining what sort of damage he sustained.
Oh, okay. Yeah, he's got aphasia, he's incontinent, both. When he first came out of hospital, he was able to dress himself and look after himself a little bit. I remember him learning to tie his shoelaces up and things like that. But then he developed complications, and that's made him much worse now.
So how do you feel about him being resuscitated?
At the time, I thought, do anything to save my brother. But as time has gone on and I've seen his condition worsen and where he's living now, well, if it was me, I'd be saying, don't do it.
And how have you felt listening to these other stories?
I feel guilty saying that after meeting you two, and I knew I would, because I see how wonderful they are. But in my position, I see my brother, and that's not for me. And I was just saying, I've said to my husband, if you come home and you see me having a heart attack, go outside and don't come back. Come back in a few hours' time. I know that's an awful thing to say, but that's how I feel.
OK, anyone like to comment on what Wendy's had to say?
I think the discussion shouldn't get derailed by talking about the incredible technology and all the things that can be done at the far end of the process. Because what's most important is actually what's done at the very beginning of the process. The definition of cardiac arrest now, worldwide, is that somebody is not responsive and is not breathing normally. There's actually not even a check for pulse in the current definition, because we recognise that people feel for a pulse and often feel it when it's not there, and sometimes when it is there, they miss it. So the definition is very, very simple. What's been shown to work incontrovertibly is immediate, high-quality CPR, which we've just seen be a success, done the very moment somebody drops, if possible. The other thing that's incontrovertibly successful is putting a defibrillator on, and if it's a shockable rhythm, as Matthew pointed out, to actually apply the shock as soon as possible. Those two things have more success than anything else.
How consistent are the systems in Australia for resuscitating people?
Every 5 years, the guidelines are developed and published based on the very best evidence from research over the preceding 5 years. Now, the actual implementation of those guidelines, so who teaches CPR to bystanders and lay people, varies because sometimes it might be an ambulance service, sometimes it might be a provider like Surf Life Saving or St John.
But there are inconsistencies, aren't there? I mean, if Colin hadn't been at the Alfred in Melbourne, he wouldn't have had access to the ECMO machine, for example.
That's true, but the inconsistencies, the further into the system you go, there's undoubtedly inconsistencies and the variability will be huge. But on the level of the things we know saves lives much more than anything else, which is immediate CPR and defibrillation, the consistency is a lot better than it is if you think about where there is an ECMO machine or not.
Peter Saul, you're an intensive care specialist. What do you regard as a successful resuscitation?
Well, I would dispute what Sam said about what death is. Death isn't just when you're not breathing and your heart's not beating and your pupils don't work. It's when the doctor says you're dead, which takes into account a whole lot of other stuff, like how ill you were, what you were like beforehand, what we know about you and how long we've already tried. So I do think that we have to take into account... We've bandied around the word death here, like Colin dead for 45 minutes. I'm very uncomfortable with that. I feel like he was in a state of cardiac arrest for 45 minutes, but he wasn't dead because here he is. So death is philosophically and legally irreversible, so I think we've got to be careful about how we use that term.
I want to go back to the question you had for Sam.
The question is, where's the systematic, if you like, randomised controlled trial evidence for this? Yeah. I would think it's anecdotal from the way you've described it so far.
No, let me explain better, perhaps. I think what I'm trying to explain is that after a person dies, the way that we define them as being dead as opposed to having a cardiac arrest is whether they had wanted to be resuscitated. So for instance, if somebody is 90 years old and they have cancer and they did not want to be resuscitated, then when their heart stops, they stop breathing and their brain shuts down and they have fixed and dilated pupils, they will be certified as being dead. That is the time of death that will go into the certificate. Now, that is biologically when death occurs, but my point is that that corpse, forget the fact that that person is elderly and they have cancer, the brain cells and other cells inside the body have not yet undergone irreversible, irretrievable damage. We simply don't know when a corpse has reached that point. And that's really the point that I was trying to make. And this is well documented in the medical literature.
Paul, what did you want to say?
I think, to be fair, and with the greatest respect, what you quoted earlier on was studies in Nature which showed you can grow neurons in a Petri dish or whatever several hours after death. Now, there's a vast amount of difference between growing brain cells in a dish and having somebody go home, pay tax and look after their kids, which is actually the definition of success that we'd prefer to use.
But there is, I have to say, in neurology we started...
agree with you.
Okay, hang on 1 second, Sam. I'll come to you in a sec.
In neurology in the last few years we've started using clot-busting drugs for stroke. And originally we thought that there was a great deal of controversy after some initial negative studies, but now we know that we can return the brain that was... a stroke is basically where a clot blocks the blood flow to a particular part of the brain. And we know that if we apply a clot-busting drug through the veins, the person may regain function of that part of the brain initially after... even if the therapy is given after 3, and lately that's been pushed out to 4.5 hours. So there certainly is increased viability of brain tissue that's receiving little or no blood flow.
But as
after
Paul's
many hours.
saying, viability of brain tissue is one thing, going home and having a functional life and...
Yeah, these are patients who receive the clot-busting drugs and have a good neurological outcome. In other words, have a significant reversal of their deficit. Doesn't mean zero deficit, but certainly markedly improved.
Wendy, you're listening to this. What do you think?
I just remember seeing some scans of my brother's brain and all these grey patches or white patches and being told that that was... they were areas of his brain that were damaged and couldn't be repaired. And you can see from the video what he's like. He can't speak and he can't toilet himself. He can't do any of those things. And now he can barely feed himself as well. So,
Sam, have you conducted a proper trial of your processes over the last 3 years?
There are guidelines that are published that deal with the quality of care that patients should receive during cardiac arrest, and then followed by quality of care for the first 24 to 72 hours in the intensive care unit. Over the last 2 years, we have tried to implement a number of these measures. It's very difficult to get everything done immediately. But through that, we've managed to increase our survival to hospital discharge from a rate of 21% to 32% in 2012. And so far in 2013, our current rate of survival lies at 38%. Most of our patients do not have brain damage. This is still a work in progress. We are anticipating writing up the results of these, our outcomes, when we've reached a full 2 years of improved outcomes and follow-up of our patients.
Are there people that you've revived that you wish you hadn't?
If somebody has a condition that is untreatable, in my opinion, they should not receive any CPR whatsoever. I go out of my way on the intensive care unit to explain to family members that we should stop and not do any CPR for certain patients that we know we cannot treat the underlying problem. Because even if we were to restart the heart, it's going to stop again and again.
But can I ask you again, in your hospital, are there patients you have revived using these procedures that you look back and, with the benefit of hindsight, wish you hadn't revived them?
Well, first of all, you have to realise I'm not a sole practitioner.
But it's a personal question,
I'm not
Sam.
aware of a
It's a question to you.
Personally, that I have.
It's a personal question. It's just a question to you. Yeah.
I'm not aware of a patient that I have personally been involved in their resuscitation and that I've regretted having done that, if that's what you're asking me, because of bad outcomes.
Okay. Stephen Bernard, you're running the trial at the Alfred, which uses similar procedures here and which Colin benefited from. What sort of results are you getting in terms of quality of life out of that trial for people?
Well, we've in Victoria, we've run a number of big trials looking at out-of-hospital cardiac arrest in the Victorian setting, and particularly the Melbourne setting. And for people like Colin who have this cardiac arrest at home, our paramedics are very highly trained and they have a drill that they go through. But with the sort of condition that Colin had, about half the patients don't respond. The other half do, and they go to hospital. And of those patients, about a half die, and of the other half, hardly any, maybe just a couple of % end up, sadly, like Trevor, in a nursing home. So that is an outcome I know that every doctor I know points to and says, whatever you're doing with research, you can't have that as an outcome. You've got to get people home and happy and having a great quality of life.
And how do you make those decisions as a doctor? I mean, how do you make those split-second decisions about whether to persevere or not?
Yep. In the hospital, we are very careful. If the family indicate that someone would not have wanted resuscitation, we're always able to stop if it's a clear case. But for the most part, the really big difficulty for doctors is after you have to let something like 5 days go by and then make some sort of judgment call using a series of tests and give the family a prognosis. So doctors in intensive care in particular, and neurologists are often sought for a second opinion, often find this amongst the most difficult decisions they don't make the decisions, amongst the most difficult opinions to form, and then together with the family, to make decisions about either continuing on with a prospect of the patient getting home, or the patient would receive palliative care and die. And as I say, a dreadful outcome is someone who ends up, with high dependency.
Are there people you've revived you wish you hadn't?
I certainly remember one patient, and I met, incidentally, his widow some years later, and we agonised over this decision. He was very young. And she did tell me later on that he suffered a lot. Having said that, we would have given up on Colin, and I guess there's a balance there, isn't there?
And I guess the interesting thing is where you draw those lines. As a paramedic, what do you do? Where do you draw those lines?
There are, as Steve described, Jenny, there are advance directives, and there are guidelines that we use to determine whether or not we would start resuscitation or not. And if people are elderly and sick, or their families don't want them resuscitated, then we don't. But, I mean, given we're talking about these 3 cases tonight, we would have gone flat out at all of them. And, you know, unfortunately, and Trevor is just the sort of guy that we would have given our all to and hoped desperately that he did well.
How long do you persist with resuscitation before you stop, though?
Our mindset is changing, but we've probably traditionally said about half an hour is enough. I have personally done resuscitations that are a lot longer, and I know a lot of intensive care paramedics in Victoria have also done so.
Paul?
I've done resuscitations on people where the CPR has gone on for 4 or 5 hours. Usually that's when somebody's hypothermic or something like that. You know, we do sometimes resuscitate people with that length of time.
Are the kind of discussions we're having about you know, raising different areas, different techniques and so on, pushing those boundaries out? Are they making them more blurred now?
They are, but I think what you've also got to think about is bang for your buck. Is that if you buy an ECMO machine, and I've never bought one, so I can't say, but I'm led to believe they're about $60,000, $70,000. If you get the most basic mannequin to teach somebody CPR with, it costs $35. Now that means, in a quick calculation, that I can buy almost 2,000 of those for the price of an ECMO machine. And if I can train 10, 20, 30 people to do immediate CPR on a patient on the beach, then I think the bang for the buck is with the early interventions.
OK, Stephen, what do you think, given you're doing the trial?
Well, I think there's room for both. And we know that there are about 60 patients a year in Melbourne, like Colin, whose heart cannot be started by the paramedics. And this is the sense that we're getting, is that the future is that we will be able to do something for those people. So that's the question of mechanical CPR, which I think you'll be showing some vision of shortly. People teach chest compressions. We want to do all that, but we also want to do more. The cooling, which has, I think, been adopted widely now around the world. ECMO for a select number of patients.
ECMO is effectively a heart-lung machine.
Sorry, yes.
Now, the big difference is that some hospitals have those machines, but they don't have them in emergency. Is that right?
Well, really the Alfred has this ability, and in Japan, they have been doing this for about 13 years and publishing quite good results. Now, quite good is for people that otherwise wouldn't have had any chance, about 20% of people going home.
Peter, what did you want to say?
I was just going to make the point that Stephen's talking about Japan and using ECMO, but they've actually got the world's worst outcomes from out-of-hospital cardiac arrest at the same time. And I think it's playing into the hands of what Paul's saying and what...
So you think all the effort's being put into what happens in the hospital but not outside?
If you're putting in the effort at that end and missing out, and I guess what Stephen's saying is you've got to have both, but if you're looking for bang for the buck, it really is in trying to get early intervention. At the moment in Australia, between 2 out of 3, or at least over half the people, would walk past a collapsed person on the street.
Colin, what's your reaction to that debate about whether the money should be put into the machines?
I can only go on my own experience. You know, I'm here and I'm healthy, and to me, it's definitely worth it. That's all I can say. You know,
of course it is.
I can see their point, though. There is definitely merit in trying to teach people young how to do these procedures that do save lives. So,
Neil, you've been listening to all this. I mean, what do you make of all this kind of discussion about the theory as opposed to being in the water with somebody who's face down?
I actually spent 3 days where I didn't know whether Cassandra would come through without any long-term problems. And I actually had a couple of people say to me, and they were actually doctors, said, I wonder if you did the right thing. And I think we sometimes forget when we're talking, you know, on a clinical level, that we're talking about someone's mum and someone's brother and someone's partner. And I think we need to respond, and we need to respond well.
Cassandra, what do you think, having listened to all the medical debate?
I think that the privilege of coming back to life, or staying alive, no matter what your definition happens to be, is that I've had 30 years younger than most been confronted with what are your life lessons. And to me, it's been, at the end of it all, it's not your house, it's not the job title, it's not any of that. It's who do you love and who loves you? And I'm fortunate in that Neil had a big enough heart to say, there's a stranger, I'm going to see whether she's okay.
I've certainly had people report the spiritual experience of the out-of-body. We've had the whole thing, the lights, the tunnels.
What people describe is a feeling of feeling incredibly peaceful.
Colin, has your health suffered at all since you were revived?
I had a bit of an issue with a blocked artery in my leg for a while, but it was nothing that couldn't be repaired, and yeah, now I'm probably fitter than I was for a long time before, so.
And any brain damage at all?
Not that I've seen.
Sinead, do you think you've been affected?
Dare I say?
Very careful.
Maybe very slight short-term memory, but yeah, nothing significant.
And other changes? Is he different
No,
now?
sharp as ever. Yeah.
Have your priorities changed, do you think?
I probably just don't stress as much about things that I would normally get stressed about. It's just not worth it.
Cassandra, what about you? Any lasting effects from what happened?
No, I don't believe so. At the time when, sort of a month after, I certainly did notice there are a couple of things that weren't up to scratch. I'm a writer and communicator by trade, and I knew that my reading out loud, as I was reading to my son, was not as good as it should have been, and my spelling and my grammar had suffered a little. But I'm very fortunate in that my son has autism, and we've spent 7-8 years going through an enormous amount of therapies. So it was great because I had the tools already, that I knew them, that I'd been using on my son, and it validated that for me because I use them on myself. And as a consequence, it's all coming back. It's fantastic. So,
So do you still have trouble reading to your son?
No, and the great thing is we've been working our way through one of the thick Harry Potter books, and when I remember when it was about January when we were starting this epic journey of Harry and his friends, and I did find it quite hard, and that was when I knew something was wrong. But now it's fine, no problems at all.
Ron, how do you consider Sandra's going?
I think she's done a brilliant job. As she mentioned, she almost rehabilitated herself. We did have the involvement of brain injury specialists initially, but they felt that there was essentially not much they could offer that was necessary. So she certainly returned to she was extremely high functioning before, and is certainly back to that level as well now.
Does she have brain damage?
No, she doesn't.
No. So did she have it, and has it repaired, or?
I mean, essentially she had deficits in brain function to start with. It's difficult to say what's brain damage and how much of the brain can sort of bypass deficits, and sort of, we know that brains are able to reassign functions elsewhere, which is called plasticity. So the brain is able to recover from what otherwise would appear to be permanent insults and work around them to return essentially to a normal function.
How much do we know about human consciousness in these situations?
I've certainly had people report what you didn't report, the spiritual experience of the out-of-body. I'm not sure about the other professionals here who've seen that. I've had it reported to me that we've had the whole thing, the lights, the tunnels. People do say it. I mean,
have other medical professionals here had that? Stephen, no?
I've looked after a lot of these patients. I'm afraid to say not one has ever reported seeing anything at the end of the tunnel.
Sam, you're actually studying this. What are you finding out?
Well, we've been undertaking a separate study which is interviewing patients after they've been resuscitated. This is a large multi-center study carried out in the US, the UK, and in Austria. But in essence, actually far more people than we thought have recollections of some sort of consciousness when you interview them. But most people don't volunteer the information, and that's why I'm not surprised that some of the medical members in the audience mentioned that they haven't come across it. And what people describe is a feeling of feeling incredibly peaceful. So for instance, if they were in pain, let's say due to a heart attack or some other process, that they suddenly switch out of it, they feel immense peace, they feel that they see a bright, warm, welcoming light, And interestingly, of course, one of the most interesting aspects is when they describe a sensation of looking down at doctors, nurses resuscitating them, recalling conversations, clothing, and various details that they really should not have known about. Well, if you think about it, the brain cells have not yet become irreversibly damaged, and consciousness as an entity does not appear to become annihilated just because you've reached beyond that threshold of death. Whether it continues, for how long, of course, we don't know, but certainly in the first tens of minutes to first couple of hours of time, it appears not to be annihilated.
Do either of you want to comment on that?
I think the memory is really interesting. It's a very interesting part of this because it is what got jumbled up. I was at a concert a couple of weeks ago, and it was this Mahler concerto, and I was listening to it, and I closed my eyes, and it was like my entire life memory. I was swiping before my eyes like an iPad, and it was pushing through really, really quickly of events I hadn't recalled ever actively before, but it was very, very intense, and I feel that my memories are being like sort of sorted and catalogued, and it's been very intense and actually fantastic because there's all these lovely things that happened, when I was a child that I'd never thought of before, and it's all being put back together.
Ron, what do you make of this with your patient?
It's interesting. I mean, we certainly know from a memory point of view that the part of the brain that really handles the laying down of memory, the hippocampus, is the part that's very sensitive to low oxygen.
Is there any way of measuring consciousness?
Apart from interacting with people, no. There are certainly ways of measuring brain responsiveness to stimuli, and we can certainly shine lights and observe how brains respond to that. We can certainly put electrical impulses into limbs and see how the brain responds to that.
But you can't monitor consciousness?
No.
And if you can't do that, how do you know when someone's gone?
Therein lies the difficulty.
Cassandra, what do you think about death now?
I'm not afraid of it, but I was very lucky in that I was confronted with death earlier on in my life. My best friend died, which is certainly very unlucky, but I had death presented to me in my early 30s. And I think that death is not an avoidable condition, but it's a very taboo subject.
So it's made you more open to it?
I'm more than happy to talk about. I've written. I do on the side. Weirdly, I'm a funeral celebrant as well, and that was way before me dying. Okay, so
that is such a great line. I'm a funeral celebrant. It was way before I died.
So yeah, I think it's probably going a bit far for the sort of customer experience, but I have given funerals. I have hosted them. I've written eulogies. I've delivered the entire service end to end. So I've been with families, a lot of them when they are just in the process of dealing with someone dying in their family, and we don't emotionally address death very well at all. When you die, it's the people that notice that you're going to care about.
And you got the chance to see who cared, of course, because you came back.
I did, and I have to say it was hands down the most emotionally confronting thing I think that's ever happened to me, because it was so moving to have not just family and immediate friends, but people I hadn't heard from in years, and then strangers as well. I mean, the relationship that I have with Neil and with Luke, the lifeguard, we just sort of sat down and held hands and cried, and it's really profound.
Neil, how has what happened that day changed you?
I think I should point out for a start that Luke is on a world discovery tour.
And that's why he's not here.
Yeah, that's why he's not with us tonight, and I'm probably to blame for that because I told him to get out there and live his life because it's so incredibly fragile. I went off with my daughter to Hong Kong and Japan and on very little notice early this year, and then decided to stay out and went to Fiji and all over the place. I think it impresses upon you the importance of your family, your friends, but also the fragility of your life and how important it is to just live it and to be happy. You know, the things that are important.
Colin, what about you? What do you think about death
Pretty much
now?
say exactly what he said. I think just get out there and enjoy it.
Are you frightened of dying now?
No, not at all. I'm quite peaceful with it, to be honest. Obviously, I haven't done something I'm meant to do yet, so... And, you know, luckily a group of people and a machine was able to give me a little bit of extra time to maybe do the things that I have to get done before it's my time to go.
Thank you so much for joining us tonight, all of you. Thank you very, very much indeed. And thanks, everyone. Cassandra wants to just have a quick word with you, I think.
It's just the first time I've seen him, so...
It's the first time you've seen him since it happened.
Yes, we've spoken on email.
Likewise.
Oh, I didn't know that.
No, and so it's...
Oh, I wish I'd known that. This is the first time you've actually seen one another since it happened.
Yeah.
Wow.
Yeah.
Oh,
You're
well.
in a lot worse state then. You look a lot better.
Yeah.
Would you mind if we recorded this? Yeah,
That's okay.
it's amazing.
If you want to, that's fine.
So this is the first time you've seen one another?
It is, and it's been great to hear him, and I hadn't realised what an integral part he'd played. The criticality of Matthew being there has, I suppose, really dawned on me, and what a privilege and what a top bloke. So.
Matthew, how does she look to you?
It's just incredible seeing how well she looks now, because normally in my job I don't really get to see the outcome sometimes of how people look.
And how does that make you feel about what you do professionally?
Well, I guess it just reaffirms how much I love my job.
I've had a lot to do with hospitals, obviously, as a consequence of this experience, and it's full of people who do it. As you say, you know, that's what makes it sing, and we're really lucky.
Terrific. Yeah. Okay, you two keep talking for a little bit if you want to. Thanks, everybody.
Thank
it's
you.
terrific.